Again, welcome everyone. I am so pleased to see faculty and students from the college here today, as well as member of the Community Advisory Board. We are all excited to have participants from around the University of Arizona Health Science and the Tucson communities. We have gathered today to make connections. We are bringing together Indigenous faculty, students, public health professionals, Indigenous leaders, and community members so we can connect education to practice, so we can connect knowledge to action. Together, we are building a healthier, more equitable world. We will have many speakers and activities today, including a presentation from our own Dr. Julianna Reece, our MESCOF Alumnus of the Year, a demonstration given by Dr. Carlos Gonzalez, Native Art Activities. However, I have been notified that he might not be able to make it today with us, and it is, well, however, our own Agnes Atakis will be leading the event, and the Blue Corn March demonstration given by Nadira Mitchell and Danica So, Miss Native American University of Arizona ambassadors. Thank you all for your participation. I also want to mention that the college has a new Indigenous health landing page on our website, where we have gathered all our programs and faculty and research related to Indigenous health in one place. It is a great way to see the many ways we are working to improve tribal health and wellness. And we will continue to post news and events there also. So please take a look and get engaged. Also, I want to let you know about the popular Indigi Wellbeing programs of events featuring Indigenous artists and experts that has been coordinated by Dr. Felina Cordova Marks and William Carson, one of our doctoral students in health behavior and health promotion. This program has highlighted many talented Native Americans with a range of interests, so please watch our MESCOF calendar for upcoming events presented by the Indigi Wellbeing. So we are here. Before I introduce the next speaker, I want to thank our faculty and staff who did so much to organize the event. Thank you to Amber Richmond. She is somewhere here with the red. You know Amber? Here she is on the side. So Amber is our manager of alumni engagement and event, and it is one of the best hire I made because it gets all of our alumni engaged with us again. So thank you, Amber. Also, I would like to thank you to our Native faculty member, Agnes Atake. Agnes, you are here somewhere? You on the back? And Agnes is so good that the university took her from us for some time to help them as well. So that will tell you how good Agnes is. And Dr. Felina Cordova Marks, who couldn't make it today. Her husband is not feeling well, so our best wishes to her and her family. And Dr. Vilia Nunes, our Associate Director of Diversity, Equity, and Inclusion. Vilia, where are you? You up in the front? All of them did so much to bring this event together. I want to share a little thing. Sometime one asked me, what is the role of a dean is? Do you know? I thought about it and I said, yeah, I know. It is hiring the best people so they can do the best job and the dean get the credit. So thanks to all of them. So thank you to everyone who made this possible here. And thanks to our graduate student, William Carson, and to Paula Hay. Paula is there. Is William here? And over there, both on the side. Thank you very much for all the help. Did so much to coordinate the invitation and registration process. They have also created the graphics to promote and host today events. Also someone who is always behind the scene who make this be available for everyone. I want to shout to Eric right before the videos here. I was just telling him, I get to see him in every good event because we rely on Eric to video and streamline and have the event for you. Thank you, Eric, for that too. We appreciate all of you and thank you all for everything you do. Also, I want to let you know that the program we did have Mr. Levi Esquera, who is the Senior Vice President for Native American Advancement and Tribal Engagement here at the University of Arizona. Unfortunately, Amber just got a notice this morning that he will not be able to make it today, so we wish him well. So now, next, I am pleased to present Dr. Julianna Reece, an enrolled member of the Navajo Nation and a board-certified family medicine physician. Dr. Reece has been serving Native community for more than 20 years through both primary care and policy work. She completed her MPH in community health here in 1996 at the University of Arizona. Her passion to show how culture is medicine in Native communities led to her current leadership position as the director of the Healthy Tribes program at the Center for Disease Control and Prevention, or the CDC as we know it. Julianna works with several programs that partner with Native communities to promote health and wellness and prevent disease using a culturally responsive approach. A visionary public health leader and a passionate advocate for health equity for underserved population, especially American Indian and Alaskan Native communities, she has improved health and wellness for so many tribal communities. Julianna will talk today about Indigenous wellness from her unique perspective and leadership position. Please give a warm welcome to Dr. Julianna Reece. Julianna?
Thank you, Dr. Hakeem, for that gracious introduction. I will be doing a presentation that kind of outlines what I do in the CDC, and it might be best if you all in the back, if you'd like to come closer, just so you can see the screen. I'll have a number of graphics here that I'll be referring to in my talk, and it just may make more sense if you're able to see it. So. Okay, good morning, everyone, and thank you so much for allowing me to speak to you today. I'd like to begin with a brief introduction in Navajo, as is customary in my culture. Yat e bine Julianna Reece nishe tkapahan nishle sen habitli bashichin kia ani eda shichedo ashihi eda shinala seot so de nasha akot astana nishle. My name is Julianna Reece. I'm from a small community on the Navajo Nation called Fort Defiance, Arizona. Like many of you, I ventured off the reservation or off from my home community to pursue education. And from the beginning of my education, I really had no idea where I wanted to focus. I knew I wanted to improve the health and wellness of Native communities, but I wasn't clear on what direction I would take to get there. And so I ended up getting a bachelor's degree in psychology initially, and from there I came to this wonderful campus, and all of this wasn't here back in that time, but I did my MPH in community health and focused a lot of my work in American Indian Alaska Native populations. From that time, I made the decision to go into medicine and continue to pursue the community-based work that I had started with my MPH here. I ended up going to medical school and residency in UC Davis in Northern California. I worked for a number of tribes there in primary care for probably 5 or 6 years in California. Came back to Arizona in my hometown and served as the chief of family medicine for the Teotso Medical Center in Fort Defiance. Was an incredible experience for me to be in my hometown, being able to do all the things that I love to do and culminating all of my skills. From there, I took a number of different opportunities that were grounded in primary care, direct patient care, but also had leadership and mentorship opportunities. And I really found that the field of public health is not, I don't think it's made aware of, I don't think the field of public health is emphasized enough to students and to youth as they are looking to pursue different careers. I just felt like there was a gap there, and talking to a number of even higher level individuals that have gone through public health careers and medicine careers, there's limited information on what else you can do with your medical degree, or what else you can do in the field of public health beyond clinical medicine. So I'll talk a little bit about what I do in the CDC. And hopefully I can inspire some of you to consider even coming to work with us, and either in a student internship, fellowship, or even as a professional. So I'll give you some information. On the table in the back, there's also a flyer with some information on the CDC opportunities, so feel free to grab those and hand them out. Let me switch slides here. Okay, and I have nothing to disclose financially, or have no conflicts of interest to this report. The objectives for the talk today will be to foster an understanding of how American Indian Alaska Native populations are unique to public health, to identify key historical laws that greatly impact American Indian Alaska Native populations, to demonstrate how social determinants of health, historical trauma, intergenerational trauma, and multi-generational trauma impact American Indian Alaska Native populations. And lastly, I'd like to highlight how CDC supports American Indian Alaska Native communities through the Healthy Tribes program. That's the program that I am the director of. And how they use the key mechanisms of social determinants of health to address health disparities in Native populations. Before we launch into specifics of the Healthy Tribes program, it's important to review a few historical facts that will help you better understand the intricacies of American Indian Alaska Native populations that make them unique to public health. American Indian Alaska Native tribes have a long, complicated relationship with the U.S. federal government. It's essential to highlight that the relationship between the federal government and tribes is a government-to-government relationship. And that's a key point that people don't quite get when they're doing public health in communities, in underserved communities. It's a very different field of work than, say, working with an African American population or another underserved group. Since the formation of the Union, Indian tribes have been recognized by the U.S. as sovereign nations. This has resulted in the transfer of land under treaties, contributing to the foundation of federal Indian relationship. The federal programs and services that benefit American Indian Alaska Natives are based on this unique government-to-government relationship. That is why this relationship is political and legal, not race-based, like other ethnic groups in America. This is a critical point I just want to reiterate again. One additional point that many may not be aware of is that only federally recognized tribes are eligible for any of the programs and services that we offer through the CDC, and obviously through congressionally appropriated funding. And there are a number of tribes that are non-recognized or in the process of becoming recognized. There are currently 574 federally recognized tribal nations across the United States. Each tribal nation is unique in their history, cultural practices, language, and traditions. Tribal nations range in capacity of public health workforce, as well as the size of the public health tribal departments and the population size of the tribal nations themselves. An example can be a small rancheria in California can have 300 tribal members compared to, say, the Navajo Nation, which is in the 400,000 range. Tribal sovereignty refers to the rights of American Indian Alaska Natives to govern themselves. Each tribal nation also differs in their own laws and policies. As sovereign nations, the federal government has a government-to-government relationship with each nation that they are bound to uphold. There have been a number of distinct acts, policies, and laws enacted throughout history that have had devastating impacts on American Indian Alaska Native communities. I'll do a brief overview of some of the significant ones. In 1830, the Federal Indian Removal Act was implemented. This federal policy authorized President Jackson the right to make land exchanges by forcibly removing 5 tribes, Cherokee, Creek, Chickasaw, Choctaw, and Seminole, from their ancestral lands against their will. Over the next several decades, more than 40 tribes were removed to Indian country, an area that now comprises the state of Oklahoma. President Jackson rationalized the removal program as a benevolent effort that gave the American Indians one last chance to assimilate and give up their culture. In President Jackson's address to Congress, he told lawmakers, quote, "Surrounded by our settlements, these Indians have neither the intelligence, the industry, the moral habits, nor the desire of improvement which are essential to any favorable change in their condition. Established in the midst of another and a superior race, and without appreciating the causes of their inferiority or seeking to control them, they must necessarily yield to force of circumstance and ere long disappear," end quote. This act set the stage for much more to come. In 1851, the U.S. Congress passed the Indian Appropriations Act, creating the reservation system to move Western tribes onto reservations. The men who created the reservation system believed that if American Indians could be confined to one particular geographical place reserved for them, they could become, quote, civilized and assimilated into American life and transformed into good Christian farmers. The reservation was established to make sure the remaining tribes converted to Christianity and became, quote, Americanized. With reservation borders, American Indians were not allowed to leave except by permission. Those who left were arrested and severely punished or killed. The federal policies were enforced by Indian agents, which suppressed tribal culture and traditional activities. Treaties were the primary method for creating reservations, but Congress suspended formal treaty development in 1871. Therefore, executive orders, congressional acts, or any legal combination recognized by the federal government were then used to establish federal reservations. In this slide, that's an actual picture of a flyer that was produced, and this comes from the museum in DC. In 1887, the General Allotment Act, or Dawes Act, was implemented, having disastrous effects on many tribes. This federal policy was designed to detribalize the American Indian by destroying the idea of communal land ownership on reservations. Again, deliberately disrupting the community-based system so critical to American Indian people. The provisions of the General Allotment Act included allotments held in trust by the United States government for 25 years. Eligible American Indians had 4 years to select their land, after which the selection was made for them by the Secretary of the Interior. U.S. citizenship would be conferred upon American Indians who abandoned their tribes and adopted the, quote, habits of a civilized life. Lastly, all unallotted land reverted to the control of the federal government and could be sold. Consequently, land owned by American Indians decreased from 138 million acres in 1887 to 48 million acres in 1934. Of note, this map does not include Alaska. In 1928, the Merriam Report noted extreme poverty in American Indian reservations, demonstrating the failure of the previous policy. Sorry, my slide skipped. Demonstrating the failure of the previous policy, the Allotment Act. The Indian Reorganization Act, also known as the Wheeler-Howard Act, was signed by President Roosevelt on June 18th of 1934. The law allowed tribes to establish formal governments with limited powers and allowed the formation of corporations to manage tribal resources. The Indian Reorganization Act offered federal subsidies to tribes that adopted constitutions like that of the United States and replaced their traditional governments with city council-style government structures. This law also enabled some tribes a means to buy back lands lost in the allotment system. In 1953, not long ago, Congress passed another detrimental resolution beginning the federal policy of termination. In 1956, a companion policy of relocation moved Indians off reservations and into urban areas. Through these policies, the Bureau of Indian Affairs planned to move thousands of American Indian people to cities and urban jobs, breaking family units, cultural ties, and familiar ways of life. The image shows an actual relocation brochure distributed to American Indians in the 1950s. The goal was to absorb American Indians into mainstream society and deliberately place them in the most unfamiliar environments to rid them of their community connections and cultural ties. Although some American Indians chose to move off reservations to urban areas, 50% returned home to their families and reservations within 5 years because there was a lack of job opportunity, education, and social services that were promised. The incidence of homelessness, poverty, substance use, prostitution, trauma, death, and mental illness was staggering and was reintroduced back into American Indian communities and perpetuated. Many American Indians stayed in the cities, creating the roots of the American Indian movement, or the AIM movement. Maria Yellowhorse Braveheart coined the term historical trauma, defining it as the cumulative emotional and psychological pain over an individual's lifespan and across generations as the result of massive group trauma. Examples of historical trauma have long been observed in American Indian Alaska Native populations and colonized indigenous groups, but more commonly referred to in Jewish Holocaust survivors, African American slavery experiences, Japanese survivors of internment camps, and many cultural groups and communities that share a history of oppression, victimization, or massive group trauma. Regardless of the time frame, historical trauma essentially results in trauma that has been handed down to subsequent generations. It can have varied effects on individuals and populations. Oftentimes, people have unsettled trauma or grief, depression, anxiety, survival mode, coping mechanisms, high mortality, increased alcohol or substance use, domestic violence, child abuse, sexual trauma, and chronic diseases. It is extremely important to acknowledge this history as it plays a significant role in the health and healing of American Indian populations and surrounding communities. Most historical trauma for American Indians is rooted in external events impacting tribal communities over hundreds of years. More common and more recent examples are the Federal Assimilation and Relocation Acts that resulted in separation of children from their parents in the 1800s and 1900s, the Indian boarding school era, and the Missing and Murdered Indigenous Peoples Movement, as well as the Indian Child Welfare Act. Historical trauma can be traced back to the onset of colonization of America, but the continued residual effects plague our communities incessantly. Massacres, disease, starvation, imprisonment, poverty, forced removal of American Indians from their traditional lands, and traumatic boarding school experiences characterize much of the history of America, contributing to cultural genocide as the undermining self-reliance. The impact of historical trauma is evident in the disproportionate health disparities we see today in American Indian Alaska Native communities. You're all likely familiar with the Adult Childhood Adverse Childhood Experiences Score, or ACEs scoring system that tabulates the number of adverse childhood experiences and how American Indian Alaska Natives show disproportionately higher scores by the age of 18 than the general population. This slide integrates adverse childhood experiences with adverse community environments, demonstrating how both set the stage for health outcomes. Essentially, this is a depiction of the social determinants of health and the impact of the environment, showing how the roots directly affect the growth and development of the entire tree. This slide is a bit busy, but I like to show it because it really puts everything in perspective and helps you understand the link between historical trauma. It includes gestational factors, childhood stressors, adulthood stressors, and how all of these ancillary elements impact chronic disease disparities that we see in American Indian Alaska Native communities today. I'll briefly go through these slides because I think the majority of you all know that if you look at any health statistic, health disparity, you're going to see pretty severe, staggering statistics when it comes to American Indian Alaska populations, Alaska Native populations, and so I won't go through each one of these, but there are some pretty staggering statistics showing life expectancy at 73 years compared to 78.5 years in the general United States population. Violent deaths, unintentional injuries, homicide, and suicide account for 75% of all mortality in the second decade of life for American Indian Alaska Natives. So if you really think about that, it hones into these social determinants that we're talking about here. Again, there's a list here of mental health and behavioral health statistics that are pretty staggering. I won't go into detail with these, but we'll say that the statistics here are just as staggering as the health statistics slide I just showed you. I do like to show this slide because oftentimes in public health, messaging is created that may unintentionally perpetuate stereotypes and create stigma. And when you one of the things that we like to do in the Healthy Tribes is present a balanced view, and I'll go into that a little bit more in future slides. But you often hear about substance and alcohol use on American Indian, Alaska Native communities, but you hardly ever hear that American Indian, Alaska Natives have the highest rates of alcohol abstinence. So making sure that positive messaging is included in the staggering statistics that we see is really important. So what do we do with all this? How do we improve the health status of populations we're working on when we have all this in front of us? And I really like the county health rankings model because they broke it down into health outcomes, how health outcomes are being affected, and using 4 particular elements to kind of describe proportionately how these are being addressed and funded in current society. And according to this model, providing clinical care only contributes to about 20% overall to health outcomes. And the majority of our funding goes into clinical services in America. If you look at the other 3 boxes, social and economic factors account for around 40%, with 30% health behaviors and 10% the physical environment. When speaking of American Indian communities specifically, some examples of the physical environment could be lack of access to potable water, multi-generational housing or lack of housing, a lack of electricity, broadband, heating, plumbing, transportation, the list goes on. American Indian, Alaska Native communities additionally have lands that are sitting near or are adjacent to polluting industries, and this can have an impact as well. I got distracted by the little bird here. So the CDC understands the complexity of this multifactorial picture that we see on the screen here, and focuses advancing health equity through the social determinants of health. So what are social determinants of health? We kind of talked about them in a number of those slides there. They're essentially the conditions in which we are born, live, learn, work, play, pray, and age. They influence opportunities available to us to practice healthy behaviors, enhancing or limiting our ability to live healthy lives. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. They determine life expectancy, morbidity, health status, functional ability, and mental health. You've heard the saying that you can tell how long you're going to live by the zip code that you live in or the zip code that you were raised in, and those statistics are very real when it comes to Indian country. We know that interventions addressing social determinants of health have tremendous potential to narrow disparities across chronic diseases and removing systemic and unfair barriers to practicing healthy behaviors is critical. The CDC takes into account all social determinants of health, but in the center that I am working in, we focus on 5: food and nutrition security, social connectedness, built environment, community clinical linkages, and commercial tobacco-free policy. This slide describes the Healthy Tribes framework. Again, Healthy Tribes is the program that I oversee. And I like this picture because it really shows the 3 cooperative agreements that the Healthy Tribes portfolio includes in a pyramid formation. The base there is the infrastructure base, which encompasses one of our cooperative agreements called Tribal Epidemiology Center's Public Health Infrastructure Program, and essentially helps to support public health services and capacity building. The middle part of the pyramid, it represents our good health and wellness in Indian country, which incorporates evidence-based interventions, culturally tailored science approaches to chronic disease prevention and health improvement. And the tip of the pyramid is our most innovative program called Tribal Practices for Wellness in Indian country. And I'll talk a little bit more about this coming up because it's probably one of the more risky programs that the CDC has ever supported. It's very exciting for us, for me. So just quickly, again, the Tribal Epicenter Public Health Infrastructure, or TECFI, funds 12 tribal epidemiology centers that are situated across the nation. And these tribal epicenters are funded by IHS, but we support the tribal epicenters through our cooperative agreement to essentially give them more funding to do the things that they need to do to strengthen public health capacity for tribes and urban organizations. This is just a quick map showing the regions where the tribal epicenters are located. The text provided TA and data analysis for many community health assessments and profiles through TechFee, helping tribal communities identify needs, including nutrition and access to traditional foods. Also supported communications infrastructure, creating fact sheets and infographics to support the tribal epicenter initiatives. Good Health and Wellness in Indian Country is our second cooperative agreement. This is the largest investment in Indian Country that CDC has ever been a part of. It was launched in 2014 and supports coordinated holistic approaches to chronic disease prevention through community-driven, culturally adapted policies, systems, and environmental improvements to achieve long-term goals for reducing rates of death and disability from commercial tobacco use, diabetes, heart disease, stroke, and reducing the prevalence of obesity. Here's a map of the GWIC recipients and subawardees throughout the nation. So you can see there are a number of tribes represented, lots of diversity in the programs that we provide. This is just a picture of a couple of programs, recipients that are good health and wellness recipients. Community gardens are often initiatives that people undertake. To the right is a buffalo. They're doing a demonstration on how to field dress the buffalo and how to utilize and prepare the meat for community members. Lastly, Tribal Practices for Wellness in Indian Country, or TIPWIC. Again, an innovative program to strengthen cultural practices that build resilience and connections to community, family, and culture. The slide shows the strategies that were developed with tribal leaders and cultural advisors that incorporate culture and traditional teachings and support practices that support healthy lives. Our current TIPWIC program funds 36 tribal communities across the country to engage cultural practices, and almost all of them include some kind of food or nutrition activity. All of our programs, communities have implemented the widest variety of food and nutrition activities, focusing mostly on making connections to traditional foods and foodways. These activities range from plant identity and mapping, native language programs, planting, harvesting, preserving, and preparation, as well as food sharing programs. This is just one example of a program who the Wabanaki Health and Wellness worked with the Holton Band of Indians to bring intergenerational groups and locate and gather fiddleheads, which are a wild-growing traditional food. Wabanaki engaged in a group of youth interns from the tribe to develop educational materials, including native language and preparation instructions, which you can see on this slide. With the Tribal Practice for Wellness in Indian Country, we conducted some focus groups to further delineate the link between cultural factors and health. Multiple studies have demonstrated the influence and impact culture has on healthy living, well-being, and mental health. Specific benefits of cultural practices have been cited as an essential component to wellness, promoting positive mental health, promoting stronger sense of identity, and healthy living practices. Cultural connectedness is a component of social connectedness. Social connectedness is one of the major social determinants of health that we are targeting through CDC, and we're finding through the TIPWIC work that the idea and the concept of cultural connectedness is just essentially a component of that social connectedness determinant. And we're finding really interesting information that we're hoping to be able to help lay the scientific credibility that tribal practices are equate to health and equate to medicine and equate to wellness. And so, again, these are initiatives that are very new and developing, and so we're really excited to be able to show you some of these pictures from the recipients here. Before I end, I want to talk a little bit about this slide. I feel it's important because it acknowledges the social justice and how it impacts the work that we do. There's been an acute societal awareness of the perpetrated wrongs and enduring suffering borne by systemic racism, colonization, and cultural erasure. These messages carry over to all parts of our lives, including science and what science means to us and how science is conducted. It is our responsibility as leaders and scientists to incorporate these notions of social justice into our work, to simply change the narrative or decolonize, if you will, the way we do things. The principles of diversity, inclusion, equity, access, and belonging prompt action to how we address health and social issues, acknowledging diversity of our communities and giving them a voice to present their needs, develop solutions that come directly from their communities as what drives resilience and sustainability. We are here to support that as a means of advancing health equity. I know I'm running a little bit short on time, so I'm going to go through these last slides really quickly just to give you an idea of what I mean by our Healthy Tribes framework. Strength-based approaches are critical when working in Indian country and really in any community. Gone are the days, hopefully, that you present staggering statistics without balancing that notion with something positive and making sure that these messages are being vetted from the community for the community. And that's one of the essential components of our framework in Healthy Tribes. This is one example. I talked about ACEs earlier, and I had this slide up in the beginning of the talk initially, but I pulled it out to kind of give an example of strength-based approaches, because you hear about the ACEs scale a lot, but you never hear about benevolent childhood experiences. And so there are ways to measure the good things and the strengths in the community. And so if you have the opportunity to be involved in how you measure indicators in communities, try to look for ways that you can balance that narrative, and it can be really impactful in your results. Culturally responsive means a lot of things, but I emphasize with my staff that trauma-informed notions and trauma-informed care principles are very important, and understanding that when working in tribal communities is critical. Again, I think you all have heard talks on cultural competence and cultural humility and the importance of personal biases that may be unconscious. So just keeping tabs on that. I'll skip through this slide. It's more of how we do the work that we do. But I really like this slide. I think it epitomizes our approach in Healthy Tribes. It encompasses implementing strength-based, community-led, culturally responsive approaches to advance our efforts towards health equity. And I do have the flyer on the table here. These slides are really just to highlight the opportunities that we have in CDC, and I am very interested in talking to any of you. Please take my email at the end of the presentation. Look into some of these opportunities, share this information. We are aggressively trying to recruit people interested in working in Indian country, particularly American Indian Alaska Native students and professionals. So a number of programs that we have to offer. And again, this is the same information that is on the slide there. The CUPS program, hands-on short-term internship programs for undergraduate students entering their junior or senior year or recent grads. There's the PHAP program that a number of people are familiar with here. Again, a 2-year program focused on early career public health professionals who have a recent college degree. And then a number of CDC fellowships and internships. All of these links are in the slides and on the table there. So if you go to the cdc.gov/Healthy Tribes website, you can also pull up this information. ORISE fellowships are very popular and extremely competitive. So it is a process when people apply to these. Just be patient. Contact me and some folks in our staff who can help you get through this process, because again, a lot of times you apply for government jobs or you apply for government opportunities, it takes a while for things to happen and it takes a while to get through the process, so please be patient with that. And then again, the Pathways program aimed at internship programs for students, summer employment opportunities, recent graduates program, and the President Management Fellows program. Again, all very specific to public health work, and we're very excited to entertain any questions about these programs. And lastly, any professionals, non-students, or people graduating looking for jobs, we have lots of opportunity in the CDC to work in many different realms of public health. And that's it. I'm sorry, I hope I didn't go too far over time.